So my name is Nancy Lesiuk. I manage geriatric outreach psychiatry to long-term care, and I also manage behavior support across the LHIN as a lead for the Champlain LHIN agency. I'm a nurse. I've been nursing for, awful to say, but I think it's about 32 years. I've done lots of different things in my career. I have a bachelor's degree in science with a concentration in gerontology, and I've been in this position for the last 7 years. We're going to present to you today the Champlain Behavior Support System with a concentration on behavioral therapists working with us in outreach. Nick Feltz is my behavior support therapist that's joined our team 2 years ago in February. We've done a lot of hard work building the foundation for behavioral therapy in geriatrics. It's kind of new in the field, but it's very much needed, and it's been a very, very growing opportunity for the young people in this field. What you will learn tonight, you'll be learning about the Champlain Behavior Support System, who we are, and an overview of the services we provide in the community. And the community spans from Hawkesbury all the way to Deep River. It's a large community. You'll have the history of behavioral therapy and how it's operating in long-term care and what we've built for long-term care residents living there. And you'll understand how the discipline supports seniors in long-term care with using applied behavioral analysis to address behavior and psychological symptoms of dementia using non-medication methods. And I just ask in the audience what kind of an audience we're looking at tonight. How many caregivers do we have in the audience? Welcome. Family members? Lots of those. Employees that work with dementia clients? Thank you for coming too. And any students? Welcome. And anybody else that I missed, I'm sure? So I'm just going to give you a little bit of history, how Behaviour Support Ontario began. 2011, the ministry announced that they had behaviour support funding for the province of Ontario across 14 LHINs. They had a tune of $40 million. So every LHIN got a portion of that funding based on the number of beds and long-term care home facilities in their LHIN. We have 61 long-term care homes in our LHIN, spanning from Hawkesbury to Deep River, for a total of about 7,500 beds. Over the last 17 years, the Champlain LHIN, which is what we all live in, we've received approximately $6.3 million to enhance services for residents with responsive behaviors. Through different initiatives across the spectrum, from community retirement, acute care, long-term care, and private dwellings. We also will be receiving an additional funding this year for 2018-2019. I'm not sure of the exact amount, but the Champlain LHIN usually gets about $1 million to the long-term care sector. So that's what I'm responsible for, is that $6.3 million and then the additional money rolling into long-term care this year. So the mandate of what we serve, older adults, younger than 65 with cognitive impairments due to dementia. The reason I say that is under 65, we can't look at populations with ABI or Huntington's. They have to have an age-related dementia for our mandate. Over 65 with age-related dementia, mental illness, or neurological conditions associated with complex and challenging or responsive behaviors, and support for their caregivers as well. So what is dementia? Dementia is a term for symptoms that are caused by an illness affecting the brain. I'm sure we've all heard on the news for the last 10 years at least about dementia. There was an article in the paper today, or on CBC, about our special behavior support unit and how they care for dementia clients there. A person with dementia may experience memory loss, changes in mood or behavior, difficulties thinking and problem solving, Difficulties with language, severe enough to reduce the person's ability to perform activities of daily living. Our goal as a system for behavior supports, we aim to minimize the need for inpatient psychiatric care. We try and minimize the need to send the patients out to the ER, because we all know that a dementia client does not do well at all in an ER situation. And we also look at improving their quality of life for the residents that live in long-term care. Our team is quite large. So we have geriatric psychiatry, behavior support, outreach nurses. They're all registered nurses. We go in as a consultative service. We have behavior therapists like Nick, and I have Sabrina, Kristen, and Anna sitting in the front. They're also behavior therapists. We have a geriatric psychiatrist that goes into long-term care with our outreach and behavior support nurses. We have a psychogeriatric resource consultant. That's a pretty big word. It's kind of like an expert educator in dementia. So in the region, we have 5 PRCs, so Hawkesbury area, Cornwall, Ottawa, Pembroke, and the Lanark area. We have a program evaluator because all this work that we do and all the money we're spending, we need to report directly to the ministry on what we're doing with all that money. And we also have administrative assistants that help us with the day-to-day operations. Our team goals, the major goal for my team that manages residents in long-term care is to keep them in their long-term care home. That's where they live, that's where they want to be, and that's where they should be. We look at the use of non-medication interventions. So we look at different ways of intervening and redirecting our residents so they don't require medications at times that they don't really need the medications. There is times that patients with dementia, unfortunately, do need medications, but we try and look at that medication flow and only when it's required, we need to give the resident the medication. We look at reducing antipsychotic medication. I know you've probably heard a lot about antipsychotic use in long-term care. You can go on the LHIN website and you can look up any home and see what their use is. I think about 4 years ago, my team received a $20,000 grant from the the Canadian government. There was 14 sites that received the money to look at antipsychotic reduction in long-term care. We did a pilot in one home in Ottawa. Their antipsychotic use was at 37%, and we got it down to 14%. Just by looking at when the patient comes into long-term care, sometimes patients have been on antipsychotic medication for 20 years, but they don't really need it anymore. Or sometimes patients are on medication because of a previous psychotic break, or they're in a psychosis, but they don't need it anymore. So that's our job, to really be the gatekeeper for when the patient or the resident comes into long-term care. We educate, and we educate. We do lots of education. We do workshops, we do huddles based on case management in long-term care. So we work directly with the staff in long-term care, RNs, RPNs, personal support workers that work directly with the residents. We do little huddles. If there's an issue or we're having a problem, we all huddle and we try and solve the problem in the moment, not wait for tomorrow. As I said, our role, so how the consultative role works with the psychiatrist. The nurses that work on our teams, they are embedded. They're not employees of the home, but they're kind of embedded in the home. So each one of my nurses manages about 400 beds across the system. So they go into the home, they do the assessments, they work up the referral, and then the geriatric psychiatrist comes in on a clinic day. And we usually run 1 to 2 clinics per month in every long-term care across the LHIN. So that's 61 homes times 1 to 2 clinics a month. They do the consultation, then the psychiatrist will come in, look at that assessment, and he'll do the treatment. He'll make a recommendation to the medical director that manages that long-term care home of the medications or the direction they should be going with in that resident. Then we treat, and then we also have the behavior support, which I spoke about, which is the non-pharm or the non-medication directions that we look at. And we always try and look at those first. And even our psychiatrists are working in a collaborative model of care with us to look at the non-pharm first. And again, we educate, build capacity. So we work directly with our partners, which is long-term care home, to offer our behavior support services, enhance their capacity to care for the residents with difficult behaviors. That's a main goal that we have. Just some of the education that we've done. I just did a snapshot of 2017, 2018. So overall, my team delivered 1,095 educational sessions, and that could be gentle persuasive approach, that could be pieces, training, framework that we assess our residents from. It could be on schizophrenia, it could be on bipolar. We actually survey the homes to see what their needs are and what kind of education they need, and we deliver that back. We've had a total number last year of 4,500 attendees, that's staff in long-term care, community, and retirement. And we also last year we had additional funding. I don't know if anybody's looked at Teepa Snow videos on YouTube. Does anybody know Teepa Snow? Isn't she a wonderful guru of dementia? She's a fantastic woman. She's an OT therapist from, I think she lives in Wyoming or something. I know she was snowed in one time when she was supposed to come here, so we had to do her on video, but she's quite dynamic. If you look on YouTube, look up Teepa Snow, she has like 1 to 2 minute videos of simple things that you can do to help with your clients, residents, family, or family members with responsive behaviors. And in the Champlain Lynn last year, we were able to train 35 Teepa Snow coaches and trainers. Those trainers will go into adult day programs. I don't know if people know what adult day programs are, but they're for people living in community that can go to a program and they can have a mental illness or a dementia, and they can have activities addressed to what their needs are, and they can spend the day there. They usually have lunch. They have different kind of round circles. So we have coaches going into adult day programs across the Lynn. And we also have coaches in acute care, and we have coaches in long-term care, and we also have coaches going into retirement homes as well. We have grown since I've been in this position. I started out in June 2012, I think it was my hire date. And back then my team was not as big as it is now, and there wasn't as much money either. But that's a good thing, we keep getting money. So we have grown. I like that slide. This is a picture, it's quite busy, but I just wanted to give you an overview of our structure. So we have a Director of Patient Care Services at the top. That's my position there, Manager of Geriatric Psychiatry, Champlain BSO lead. In urban Ottawa, we have 29 long-term care homes, 10 psychiatrists, 15 nurses, 1 social worker, and 2 PRCs that go into those homes. In rural Ottawa, we have 31 long-term care homes, 10 psychiatrists, 10.8 nurses, 1 social worker, and 3 PRCs. I just wanted to mention as well, all the geriatric psychiatrists come from the Royal Ottawa. They all work here, and they all do outreach across the whole. So it's quite diverse. We have 3 behavior therapists in urban Ottawa, and Nick is one of them, and Sabrina is one of them there. And then we have 2.7 behavioral therapists in rural Ottawa. Anna is up in Pembroke, and Kristen is up in Lanark. And we have a 1 full-time staff that is my program evaluator. I call her my right hand, actually. I couldn't do all my work without her. We also have the 20-bed specialized behavior support unit, which is at the Pearly Veterans Rideau. It reopened on April 2018. It was previously at Peter D. Clark. I don't know if any of you knew about it, but it's now reopened at the Pearly, and 20 beds, and it is full at this point, and we have a wait list. We have additional nurses and behavior support champion program in long-term care. So with the $6.3 million funding, we actually identify personal care support workers and RNs or RPNs in long-term care that we actually give extra education, and they are only working on patients with behavior support issues. We have 8.5 FTE geriatric psychiatry in the community, and we have 4.2 nurses in acute care among 4 hospitals. So we have a full-time at the Queens Bay Carleton that does behavior support. We have at the Mulfor, we have the general campus and the civic campus of TOH. So those positions are really key for us working in long-term care, because if a patient goes from long-term care for a medical problem to the ER and is admitted, we directly collaborate with those nurses so they understand the plan of care from the responsive behavior end. So we all try and work in collaboration as a system. It's a pretty big system, and I'm not saying we do it 100% at all, but it's work in progress, and I think we've made a lot of roads, positive roads, towards making the least pressure for the patient when they move from place to place in that transition. Our strength and our growth is truly our partnerships with everyone we work with. Long-term care, retirement, community, police services, ambulance, it's across the spectrum. We work with them all. We work together to increase our capacity of all of us and all of you across our system. We're caring. We like to look at delivering person and client-centered care. The first and foremost thing that the staff that work for me, the nurses, they're experts in their field, and they have a passion for this work. They wouldn't be doing this work if they weren't passionate for the resident and for the people we serve. Our engagement, we foster a culture of collaboration. We work across spectrums. We don't want to look at roadblocks. We're all in the circle of care for the resident for the best outcome for them. I'll just give you a brief, I talked about the behavioral support unit. It's a transitional unit, so I'll just give you a little example. So if a patient's or a resident's having difficulty in long-term care, we would bring them into the Royal Ottawa inpatient unit, the geriatric inpatient unit, for about 60-day stay, because 60 days is the number of days that they wouldn't lose their long-term care bed. If that resident needs more time, that they can't go back to that long-term care home yet, we would look at sending them to the specialized behavior support unit so they could have an extended stay. They can stay there 9 to 12 months till we build a really robust care plan that our hope is that we can get them back to their original long-term care home. And in saying that, I know I said they lost their bed, but if they're going back to their original long-term care home, they get first choice of readmission back to their long-term care home when a bed comes available. So it's a 20-bed unit. It's located at the Pearly Rideau Veterans. I have a full-time RN that works in that unit Monday to Friday. She's responsible to do all the consults across the LHIN, because we get admissions from acute care, directly from long-term care, and then from the Royal. So we have 3 admission points. So that nurse is responsible to go out, work up the consult, then we have a second-level psychiatrist come in, and then we decide if they're appropriate for the SBSU, or are they more appropriate to come to the Royal. We have to make those decisions.
So I'm Nick, as Nancy said. I'm one of the behavior therapists on the outreach team. I guess we also kind of, as we're going, I'm realizing we didn't say how residents get access to our services. Yeah. So we run on the same mandate as our team, obviously, but in collaboration, our nurses and the directors of care kind of collaborate on the residents that they refer to behavior therapy services. So we kind of form this triangle of services with the nurses and the psychiatrists, and then we're kind of the other point on that triangle right now. So the nurses consult kind of both those other points. Hope that's clear.
What is behavior analysis? It's about people and the scientific study of their learning and behavior. Over 100 years ago, the underlying philosophy of behavior analysis was introduced. The best way to understand people is to focus on their behavior, the things they do and say. Over the next few decades, this viewpoint inspired a number of researchers who discovered the general reasons why people do what they do. Their core discovery was that the events immediately following behavior determine whether it will be repeated in the future. This is known as the principle of reinforcement. In the 1950s and 60s, researchers began using these discoveries to improve people's lives through behavior change. These efforts led to the development of an applied science called Applied Behavior Analysis, or ABA, the foundation of our modern-day practice. Today, there are tens of thousands of credentialed behavior analysts who help individuals, families, communities, and organizations achieve meaningful behavior change. ABA treatment has shown to be effective in solving problems in a variety of areas. ABA is best known for its success in treating autism spectrum disorder. Decades of research have shown that intensive ABA treatment is the most successful approach for children with autism, and in some cases can eliminate almost all symptoms. ABA treatment has been widely recognized as an effective treatment for autism spectrum disorder by a number of sources, including the U.S. Surgeon General, the American Academy of Pediatrics, and the National Institute of Mental Health. Parent training programs based on applied behavior analysis often teach biological and foster parents the skills they need to create safe, positive, and nurturing environments for their children. Recent research has shown that state-administered ABA parent training programs can keep families together while reducing state costs. In the area of organizational behavior management, consultants improve employee performance, workplace culture, and business outcomes by assessing and changing the work environment of its employees and leaders. A popular specialty in this area is behavior-based safety, which is a widely recognized and effective method for keeping employees safe and healthy while on the job. In dementia treatment and elder care, behavior analysts treat aging-related issues such as memory problems, health issues, wandering, medication adherence, and more. Over the past 50 years, behavior gerontologists have demonstrated that their services can improve the health and quality of life of older adults. These are just a few of the areas that applied behavior analysis has improved lives. And there are many more areas where behavior analysts are working hard to address the world's problems. If you would like to learn more about behavior analysis, visit the following websites for more information.
Frequently asked questions that I get often from crowds when I do talks like this are, what is behavior analysis? So I pulled the video. It's fairly new, so I hope it explains a bit of it, and I'll kind of guide you through some of it. What do you do is a pretty big question around a behavior therapist, because we are a new discipline in most populations. How do you assess behavior? How do you treat behavior? And why do people engage in problem behavior? So I hope I can answer a bunch of these today. So what we do, and then again, this is very broad too, but we study behavior, we observe behavior, we analyze behavior, and then we recommend. So basically, we try and pull in the entire picture around a behavior. So basically how we assess behavior begins, we generally start with a case review after a referral to kind of see what's going on, what the actual challenge is, where the maybe skill deficit lies, just why we're needed. So after that, we generally go to questionnaires and interviews with loved ones, family members, caregivers, really anybody who can give us any information, which kind of guides our next step, which is to directly observe the behavior. So we really want to have an unbiased opinion on what's going on. I know interviewing people generally doesn't help with that, but that's what we get paid to do, essentially, is go in and actually have time to directly observe what's going on and kind of analyze all the findings. So we just really want to review everything that we found. What we're looking for, the big things are triggers for behaviors, common triggers, common rewards. They call it reinforcement in the video, so we're going to call it rewards just to reduce the technical language. Challenges in routine or changes in routine or daily life. Any illness, dementia itself is an illness, so it has kind of its own emphasis on behavior or impact, I guess. Ongoing stressors, is there any sleep pattern disruptions, dietary issues, medications, and staff dynamics as well. So with medications, what I wanted to point out was just that we're mostly looking at the effects of them, when and what's prescribed, and we don't do that. So we're not the medical professionals. That's why it's awesome that we are really fortunate to work with the psychiatrists and nurses. But we're really all working together to see the impact of all the treatments and interventions that we put in place. Caregiver dynamics as well. Basically, sometimes we're looking for approaches, stuff that works, stuff that really isn't working. Is there any staffing patterns that might be disrupting or causing behaviors? And is there kind of preferred and non-preferred staff? How are those interactions any different? And really, we're just looking at really everything that surrounds a behavior, what might be possibly contributing to it, and what has changed recently or what's been ongoing, anything that we can get on that. And we want to really rule out all of the logical reasons for a behavior. In dementia care, I guess the biggest kind of, I lost the word, but our biggest enemy as behavior therapists is kind of a delirium, because it's quick to come on and sometimes can be quick to go off. So by the time we're in there assessing, sometimes it can be gone as soon as we get in. So when we're assessing, what we do is typically collect a lot of data and we kind of put it into graphs. So I'm not going to get into these, but we're looking for kind of common triggers. So for example, if Mr. P, every time 60% of the time he's redirected, there's a physically responsive episode. Well, then we know to look into maybe the redirection tactic. Is it redirection as a whole? What is he being asked to do? There's a lot of questions that can come from that. And then the rewards, or what's occurring after a behavior, is really important as well. So that's kind of, these are the two main things that we're trying to tease out. How often is a behavior happening? Now, is there certain weeks or days that are worse than others? Is it increasing or decreasing? Has it suddenly spiked? Has it been ongoing for a while? Really just looking at behavioral patterns as a whole. Some days of the week, this has been really helpful in a couple cases where in this graph, for example, you can see maybe Thursday is not such a good day for this particular individual. And so then the question becomes, what's happening on Thursday? But more importantly, what's happening on Monday, Tuesday, Wednesday, Friday, where everything's going well? So not just focusing on kind of what's challenging, but what's actually going well and how can we incorporate that? And it could be anything. So Thursday might be the day that he sees a dentist every week, or who knows? It could be a lot of things, case by case. This one's been a blessing too. So kind of analyzing patterns over times of the day. For this particular individual, there was nothing going on in the morning. So really, what's going so well in the morning? And between 2 and 3 o'clock, and about 9 o'clock, there's some spikes. So we can really focus on those times to observe, and then observe on the good times as well to see kind of what's happening as a whole. So other, different shifts that are doing something different. Is the dynamics change? Have less staff come on board? Is that maybe a problem? Specific times a day. And so yeah, there's a lot of questions we can pull from this information. So locations in the long-term care home, there was a specific case where, there's certain areas that can be more challenging for individuals than others, or better for individuals than others. Obviously, care areas can be a big challenge, but, what's going on in specific rooms or areas of the home that maybe we can look into. So all these previous slides, they basically help us investigate behavior closely. And once we can really identify where the problem is, then it helps us really hit the problem head on and not pull maybe a Band-Aid solution over it, or and we can really give it quality information to the people who need it. So recommendations for behavior. So I know we're focusing a lot on preventative behaviors here because unfortunately that's what a lot of our referrals are for, just because of the risk that it poses. But preventing behaviors is something we'll focus on very heavily. Different approaches or routines. So there could be different routines. The big one that comes to mind is first and second sitting of meal times. Maybe, the first sitting is a little chaotic. So second sitting might be a little less stimulating for some individuals. Can we give whatever they're receiving for engaging in the behavior, so the reward, can we provide that a different way for a more desired behavior? before they need to feel inclined to engage in a problem behavior, or before that needs to happen. So really, prevention's a big focus in dementia care. In other populations, when we try and kind of decrease a problem behavior, we typically try to increase a more desired behavior, if you will. And the challenge with that in dementia care is the obvious dementia and the cognitive abilities. Sometimes you need intensive supports to do that, which aren't always around. So preserving abilities is another. I really want to focus on that because it's not talked about a lot in here, unfortunately, but there's a lot of literature and a lot of behavior analysis that's focused on modifying environments to preserve the skills and abilities that remain, and providing cues, like the washroom or toilet signs really come to mind for this one. The yellow bands for folks who wander and maybe will turn left when they should go right. Sometimes those can be a cue to turn away. So cues in the environment and caregiver approaches as well. If we can prevent some behaviors with a pro-attention plan, for example, it can go a long way. So our goals for the residents, number one, I think for every discipline is to improve the quality of life, and not only improves, maintaining quality of life is a big one as well. So that's a big part of it. Individualized care plans. We really want to incorporate values, preferences, really anything that we can get our hands on that will be helpful, beneficial. And I apologize, I'm going to give a few examples here, and I'm realizing now that I really picked on the caregivers, and I didn't mean to do that at all. You guys worked super hard and are the backbone of this, so I apologize in advance. So some examples of why an individual may engage in what some people might define as a problem behavior or an undesired behavior. So if you, for example, take a resident who needs assistance from a caregiver, right? And what they really ultimately want is attention from a caregiver to tend to the need. The most desirable response is this right here in a long-term care facility, right? The call bell. Well, if, for example, a caregiver or a staff member is busy or doesn't hear the call bell or isn't in the room, or everybody's in the dining room and they don't hear it, well, your next response to get somebody down there it can be just, for example, a vocalization. And we see this time and time again, it's pretty effective in getting somebody to respond. So next time, what is the resident likely to engage in when they need caregiver attention, right? The call bell's pretty quick to go out the window. And there's also times where people have cognitively declined and they can't use a call bell anymore. Physically, they may not be able to use a call bell. So really looking into those as well. We had this exact example actually, and the individual was being placed in his wheelchair just where he couldn't reach the call bell. And when we actually gave him the call bell and said, "Can you press it?" he couldn't anyway. So, that was kind of a simple fix for just get a modified call bell and place it with him, and that reduced it a lot. So, just looking into these things that can be missed amongst the chaos. So this is a big one too. So I tried to choose some common examples. Asking to sleep in, or I don't want to go to breakfast today. The desired response is no, thank you. I'll skip breakfast today, right? And if we go in and keep prompting the individual to come to breakfast, and it may be inadvertent, it may be one caregiver goes in, doesn't see the other one go in, and then now 3 people have come in and woken Margaret up here, or whoever this lady is, and then you get this old trick that is pretty effective in getting people to go away, right? And you can go right back to sleep. So if we're not kind of giving what they want, and it goes for all behavior, but if they're not getting the kind of reinforcement, the reward that they want, there's ways to adapt to that, and we all know them. So. I think you guys are getting the picture, but if there's an unwanted meal in front of you, the desired response is to ask for another meal, or and if that's not really effective, well then we could go there. And there's ways to alleviate this as well. You can provide a menu, show them the options, let them choose. And a lot of these things are being done, but just another example. And then, for care, for example, it's asking to maybe have a shower. I know I shower in the evening, and if we continue to prompt or push it, you might get the pretty effective also. And again, I picked on caregivers, and I apologize for that. I just wanted to give some straightforward examples. This can happen between residents. It can happen between family members. It happens with us. It can happen really with anybody. It's behavior. You're just adapting to what's going on. So really, behaviors do come from the environment around them, around individuals, and it's not necessarily about what the behavior looks like. And a lot of people get caught up in that. And what's important is the actual reward for the behavior. What are they seeking? What's the purpose? What are we getting from engaging in this behavior? All behavior has a purpose, and that's kind of the punchline here, is that there is something that's being obtained for engaging in a behavior. Even if you think about your day-to-day, there's really not a lot of behaviors we engage in for absolutely no reason. So a common example would be if a room catches fire, right? There's probably the most common response is to head for the door. With this door, you'd likely push the handle. If there's no door, you may head down the stairs. You may head out a window. You may head out a different door. You would have to open those doors differently. One's a turn and pull, one's a push. All of those are different behaviors. They look differently, but ultimately, we're getting out of the room, right? So it's about the purpose and what's received for the behavior. And that's really what we're after. And really what we're trying to do is then tip the scales towards desired behavior to reduce the likelihood that there's a need to adapt to your environment, engage in challenging behaviors. And that's really what we're looking for, and trying to provide recommendations for. So in the literature of behavior analysis, geriatrics as a population is very new. The States, US is really way ahead of Canada in the behavior analysis world. We've learned a lot from them. And there's a lot of literature also coming out of the US, and they've been successful in reducing symptoms of dementia such as hoarding, vocalizations, physically and verbally responsive behaviors, agitation and wandering, and then of course preserving current abilities. There's a lot on participation, in communication, activity engagement, in continence programs, so toileting, preventative toileting routines, things like that. So there's some coming out of Canada as well. We're doing all right, but and then just so you know, I'm not lying. There's a whole bunch. So the headlines in the media, I'm obviously going to kind of table the elephant in the room. We've all heard them, and there's no shortage of those either. But what I really wanted to emphasize was these two graphs that, they're reporting a lot of incidents happening and a lot of antipsychotic reduction happening. But the response is if you kick a leg out of the table and don't replace it with anything, it's going to fall. We need to be replacing that and working in intercollaborative or interdisciplinary settings together to kind of treat this situation. Now, and I know there's the BSO, the ministry, Behaviour Supports Ontario, who funds us, the ministry, all the employees in our team as well. We're all stuck in the same system. We're basically all doing the best we can with what we're given. We're faced with the same system limitations that everyone else is, and we're all in it together. So it comes down to what can we do with what we're given, and that's really what we hope to help figure out. So just at a final glance, behavior therapy or behavior change takes time. Nothing's going to change overnight. There was a really smart guy once told me, you straighten the tree when it's this big, not this big. In geriatrics, all the trees are this big. They have a lot of history, a lot of learned behaviors. It's no surprise that a lot of these folks can engage in the behaviors. They've had a lot of experience with life and a lot of kind of rewards in the past for certain behaviors. So just to bring kind of expectations that behavior change doesn't happen overnight. We offer a new discipline for the Champlain's geriatric population, which is really exciting, and we're kind of hitting it at a really big time. And we're trained to see behaviors through a different lens than other disciplines, so that's really what we bring to the table. And again, just because we know behavior, it doesn't necessarily mean we can shut it off. And I think reduction is a more attainable goal in most instances. There's still going to be triggers. There's still rewards that are evident for certain behaviors that are going to get you what you want quicker than the more desirable option. As much as we'd like to be, we're not a cure for dementia, but we're kind of here to, like I said, do what we can. We have the same limitations as everyone else: the system, funding, staffing. If we can't alter the environment, ideally, again, there's ideal with our interventions, and then there's feasible in a lot of environments. So it's really important that we kind of strive for the ideal, but we got to do what we can with what we're given. Our team as a whole really offers a culture shift that is really important. And it can really improve the medical model of long-term care and geriatric care as a whole. And I think that culture is really important. I think the key to that is the collaborative models that we've built, that there's people looking at all angles of these things and really working together for to improve the quality of life of these folks. So thanks for listening. Thanks for coming out in the cold.